How's it going, guys? We have a pass level question for Heme Immuno, 67-year-old woman, 6-month history of mid-upper back pain as well as pain in her right humerus. Results of serum protein electrophoresis performed. So A is our healthy individual on the left, B is our patient. You can see the distinction that in our patient, we have a gamma spike. This is a kappa lambda light chain IgG spike. It's known as an M protein spike. M does not mean IgM, it means monoclonal. So this is characteristic of multiple myeloma when you combine this SPEP finding with symptoms such as back pain. You can get bone pain elsewhere, such as in the arm, lytic lesions. Okay, I've seen this on NBME exams. So for TCK3, we would go on to do a bone marrow biopsy showing greater than 10% plasma cells. What's most likely seen as patient choice A, 6% plasma cells in biopsy is wrong because this would be MGUS, monoclonal gammopathy of undetermined significance. If a patient has an SPEP performed for whatever reason, and we see a spike like this, we would say, oh shit, maybe that's multiple myeloma. We do a bone marrow biopsy, and if it's under 10%, it's MGUS, not multiple myeloma. In addition, MGUS is almost always asymptomatic. If a patient is symptomatic, e.g. lytic lesions with back pain, hypercalcemia, Bence-Jones proteinuria, then we worry, and that's multiple myeloma. But asymptomatic under 10%, that's only MGUS. There's a small chance of progression to multiple myeloma every year. Wrong fucking answer. Choice B, plasmacytoid cells, 12%, bone marrow is wrong. OID means looks like but ain't. So plasmacytoid cells look like plasma cells, but they ain't plasma cells. This is Waldenstrom macroglobulinemia. It's an IgM spike, not IgG. And you get hyperviscosity syndrome, headache, blurry vision, Raynaud phenomenon. You do not get lytic lesions. You do not get hypercalcemia. You do not get Bence-Jones proteinuria. So we have those distinctions there. Wrong fucking answer. Choice C, Raynaud phenomenon is wrong, as I just harped on. This is part of hyperviscosity syndrome, which is seen in Waldenstrom, not characteristically multiple myeloma. Wrong fucking answer. Choice D, reduced serum PTH, correct answer. So not dramatic. If you have lytic lesions with hypercalcemia and multiple myeloma, then we would have increased negative feedback of the calcium sensing receptors, the parathyroid glands, decreasing our serum PTH. So even if that seemed a little bit difficult to arrive at that, we can eliminate the others to get there. So let's look at the final one. Systolic dysfunction is wrong. You need to know that in multiple myeloma, we can get cardiac amyloidosis. It's the highest yield cause of cardiac amyloidosis in USMLE, which causes diastolic dysfunction. Amyloidosis means protein depositing where it shouldn't be depositing. So the kappa lambda IgG light chains, those are proteins. So they deposit in the kidney, cause renal amyloidosis. With the apple green birefringence Congo red stain, that's a nephrotic syndrome. Deposit in the heart, you get the same type of birefringence, but that's diastolic dysfunction. A stiff left ventricle, preserved ejection fraction, S4 heart sound, whereas systolic dysfunction, you get a floppy left ventricle, S3 heart sound. Okay, so they like that, and you just have to know these different findings. Rouleau formation, another high yield one for multiple myeloma, where those IgG kappa lambda light chain spikes are sticking to the RBCs, which cause the RBCs to stick to each other in sediment. Systolic dysfunction? Wrong fucking answer.